All right, we'll get started so we keep on time with the next session. So thank you everyone for joining. So this is a session focused on the Navitor valve. I know the title showed TAVR in the era of lifetime management beyond high-risk patients. But I think when we came up with the session content, we decided just to pick a selection of cases. We'll have some data at the end, but just a selection of cases that kind of highlight some of the key features of the Navitor system and kind of where it can be applied. So without further ado, I'll introduce our first speaker, Dr. Hatem Al-Luati, who will be speaking on an axillary access case. Auxiliary access case, sorry.
Okay, Assalamu alaikum. Good morning, everyone. Thanks for attending our session. I'm going to present a case where TAVR was performed from an auxiliary approach, to be more specific, from an axillary approach. The case I'm presenting was a 73-year-old, really frail old woman who weighed only 36 kilograms. She was hypertensive, dyslipidemic, and had very aggressive peripheral vascular disease, as you will see. She was referred to us for further management of highly symptomatic, severe calcific aortic stenosis. Her echocardiogram at our center revealed a preserved LV systolic function with an LV ejection fraction of 58%. The aortic valve was heavily calcified, trileaflet, with a mean gradient of almost 70 millimeters of mercury and an aortic valve area of 0.57 centimeters squared. She, in addition, had moderate mitral regurg, moderate tricuspid regurg, and mild pulmonary hypertension. The rest of her lab investigations were unremarkable. Her electrocardiogram revealed sinus rhythm with normal AV conduction time and QRS duration. Her coronary artery, the coronary angiogram revealed a moderate plaque in the ostial and proximal circumflex and a long calcified plaque in the proximal and mid-LAD, as well as the mid-right coronary artery, which the heart team decided to manage conservatively. Her vascular surveillance revealed quite exuberant calcific plaque in the distal aorta, surprisingly. She had an aneurysm just above the distal aortic bifurcation. And if you look at the cross sections in the aorta, at the level of the renal arteries, in the common iliacs and external iliacs, very calcific, obstructive disease, making femoral access unfeasible. Further vascular surveillance revealed surprisingly disease-free vessels in the upper extremities. If you look at the running clip here, her left axillary and left subclavian arteries were relatively disease-free, albeit quite tortuous in their course, as you see in the running clip. And there was some plaque in the proximal segment, and hence we decided that we should probably use this approach for the implantation. Further analysis revealed an annulus with a perimeter of 68.6, area of 360 millimeters squared, a minimum diameter of 19, a maximum diameter of 25, and an average of 22. The coronary heights were adequate. We decided, given characteristics of the delivery system, to use the Navitor valve here and selected a 25 millimeter valve for the implant. The reason why we selected the Navitor system is because of the ergonomic profile of the delivery system, the FlexNav system, with its flexible capsule, flexible shaft, and hydrophilic coating. And we've seen this case where the Navitor system was able to navigate very hostile vascular anatomy, leading to a successful implant. An angiogram was obtained from the left radial artery through a multi-purpose catheter, showing a relatively disease-free artery that appeared to have straightened with the catheter. And there was plaque noted as well at the proximal subclavian artery. After pre-closing the arteriotomy with two prostyle devices, the arteriotomy was sequentially dilated with 9 French, 12 French, and then eventually 14 French. And this is where the first challenge was encountered. The dilator had some difficulty making that 90-degree angle into the aortic arch, and after a little bit of push and pull with the wire, it eventually made the curve into the ascending aorta and dilated the tract. After inserting a 14 French sheath, the aortic valve was crossed in the standard fashion. The valve was pre-dilated with an 18 millimeter ZMET2 balloon, and the 18 French sheath was exchanged out for the, 14 French sheath was exchanged out for the FlexNav system. And this is where the second challenge was encountered. So the valve actually got caught within the plaque in the proximal subclavian and wouldn't make that 90-degree angle. We eventually pulled back the delivery sheath, and applying forward pressure on the FlexNav catheter allowed the valve to make that 90-degree angle down to the descending aorta and drop into the annulus where we wanted it in the first place. So quite a flexible delivery system that allows you to negotiate challenging anatomy. The valve was deployed in the standard fashion, a little lower than we'd like it to be. There was a little bit of a paravalvular leak, and therefore the FlexNav system was exchanged out for the 14 French sheath. We had a balloon for tamponade, and therefore there was a dry exchange where the FlexNav system was removed. The 14 French sheath was reinserted. The prosthesis was post-dilated with a 22-millimeter balloon, and there was no paravalvular leak at the end of the procedure. Not sure why the videos are playing the way they are, but I think you can see that the final result was quite acceptable. The other challenge encountered was after tightening the two prostyles and applying an 8 French angioseal, we still had some active extravasation from the access site. But balloon tamponade was then applied for 15 minutes, and the final result showed complete hemostasis at the access site, and the patient left the cath lab with a Band-Aid. So transaxillary access is a viable option when we don't have a readily available transfemoral access for the implantation. This is data from the ACCESS study showing that transaxillary approach has an upwards of 97% success rate with a very low risk of vascular access site complications, strokes, and a low 30-day mortality. This was another analysis from a series of observational studies comparing outcomes in non-femoral TAVR stratified by transaxillary approach, transcaval, and transcarotid approach. And albeit transaxillary approach had a higher risk of CVA and TIA at 30 days, there was no increase in the risk of 30-day mortality or length of stay, and no other access site complications noted. So transaxillary approach remains a viable option, particularly when we're dealing with hostile femoral anatomy for transcatheter aortic valve implantation. Thank you.
Beautiful, Hatem, beautiful case. I think it illustrates the deliverability of the system. And what I like about this system, and you have shown it very clearly, is that first, the nose cone is atraumatic. So I think this is very important. The prosthesis itself is flexible, so it takes the roots of the arteries. The other thing is the integrated sheath. The integrated sheath is very hydrophilic, so you can rotate clock and counterclockwise. So it helps you that you can rotate. You change when you rotate, you change the axis at the nose cone and the system, and it takes the care. So I think it was shown beautifully in this case.
Yeah, speaking to the atraumatic nature of the nose cone, I don't know if you've noticed that. I forgot to highlight it, but at the end with the last injection, the plaque at the proximal subclavian artery was undisrupted. So it didn't damage the plaque there despite the push and pull on the delivery sheath, on the delivery catheter.
Hatem, this is really elegantly done. I mean, I don't think I've seen groins that more hostile than this. Just a couple of tricks when we're using the axillary is, I know it gets very crowded when we're working up here because this is also where your anesthesiologist is. This is probably where your echocardiographer has their stuff parked. But sometimes what helps is actually, if the patient is in, awake but moderate sedation, is to have them take deep breaths. That sometimes helps us with the catheter, with the delivery sheath, but also manipulation of the arm. And I know it's difficult sometimes because it is crowded and you want to maintain sterility, but in fact, sometimes raising the above shoulder level can help slide that delivery sheath a little lower. But again, fantastic case, very impressive.
Yeah, that's a very, very great case, very challenging. Question about the pre and post is not, I don't usually have to do it with the Navitor system. That was a little, but it was very nice. I mean, it went away afterwards. I was a little surprised that you had so much leak after the first, because it wasn't a lot of LVOT calcium, it seemed like, on the CT.
That's right, that's right.
Yeah, but it was a beautiful final result. I mean, the leak completely went away afterwards.
The other thing about your deployment, now when you think you are deep and the system is not at the greater curvature, I think one trick I learned is that you push it to the greater curvature. So it slips the valve in the good direction, although it's deep. But if it is at the lesser curvature, then you have to go back and adjust it. But usually, if it is deep and the cusp overlap and the system is middle or towards the lesser curvature, you push it.
Yeah.
You push it and it adjusts the valve. That's one of the beauty of this valve also in this direction. Ali.
So sorry to interrupt. Pertaining to this particular technique, it applies beautifully when you're doing it from the transfemoral approach, because then your delivery system hugs the greater curvature or the lesser curvature of the aorta. But we've noticed when we're doing it from the transaxillary approach, the moment you try and lie the delivery system on one of the either curves, it actually either dives or comes back up. So the best way to fine-tune your position, we found, was to do it with the wire, with the LV wire. So you pull it, the system dives in, you push it, the system gets pulled back.
This is an excellent case, Hatem. Congratulations on the nice result. I have a comment and a question to you. The first comment is, this is a 23 millimeter Navitor valve, so the lumen diameter of the axillary and the axis is different when you use that valve in comparison to a larger Navitor valves. So if you go with a 27, 29, or 35, you need a larger vessel that accommodate the larger size. A lot of people shy away from transaxillary access because of concerns regarding failure of closing. What's your strategy in terms of closing those arteries? Do you use 2 proglides with an angioceal, 3 proglides, and what do you do if it fails?
So what we've done with a few cases that we've done transaxillary is we pre-close with 2 proglide devices. If we achieve hemostasis, well and good. If not, we chase it with an 8 French angioceal. And then what we do is when we are tamping the collagen plug with the angioceal, we make sure that there's a balloon inflated inside the vessel, so you're tamping on the balloon. There's a lot of soft tissue in the axillary area, so if you're doing it without the balloon support, you're actually pushing the vessel down. If you have a balloon inflated inside the axillary artery, you achieve a better flattening of the collagen plug. If that doesn't work, then you have your balloon for inside the axillary artery, so you apply balloon tamponade for however long you need to achieve hemostasis. And if that still doesn't work, you have your balloon up there, your patient is not losing any blood. We have a surgeon on our team who can, via a quick cut down, repair the artery and achieve us the hemostasis we want.
Thank you.
There's also the option of putting in a covered stent. So that'll be, so the surgery will be a last resort. We have low-profile, self-expandable covered stents that can go through the radial approach, or you can even have your access, the safety access from the femoral approach, where you can put a covered stent through an 8 French sheath.
Thank you.
So multiple options for hemostasis there.
Thank you, Hatem. Now we'll have Dr. Mahmoud Traina. He will show us a left main BCI through TAVI after transcarotid TAVI. So two issues.
All right, thank you very much. Do I have to load? All right, so start with a case. You know, I'd say it seems like the Navitor system, I tend to use it in my most difficult cases. Rabia knows this, difficult anatomies. But this is a 77-year-old male, history of complex past medical history, coronary disease, multiple PCIs, paroxysmal AF, end-stage renal disease patient, and a PAD with dry gangrene of the toes, toe amputation on the left foot, and likely need for further amputation. Now he presents with refractory heart failure symptoms in spite of adequate dialysis. Echo shows the EF 40%, valve area of 0.8, mean grading of 28 with a DVI of 0.21, moderate MR, and severe coronary disease with a distal left main bifurcation calcified stented lesion, which I'll show. So here's the coronary anatomy, just a horrible coronary anatomy. You can see all the stents, some edge restenosis of the LAD stent and the circ, and just a kind of complex bifurcation lesion. The right shows some moderate disease. So the echo shows, here's the valve, not super critical, but a tight valve, and you can see the moderate MR. So when we looked at the CT analysis, and basically the vascular guys wanted to do a toe amputations, obviously not a candidate for anesthesia with his left main and severe AS, and so it became chicken or egg, and we kind of got forced to do something on this patient. Annulus measures 75 in the perimeter, 413 in the area. LVOT was fine, good sinuses in terms of their size. STJ was a good size, calcified but good size, and good coronary heights. Peripheral anatomy wasn't critical, and so it wasn't as bad as Hatem's case, a horrible peripheral anatomy case, but it is pretty diseased, and there's a lot of distal runoff, and the concern was about going femoral with his distal vascular disease and already has gangrene, is to further compromise the feet, and so we decided to go transcarotid in this case. Valve choice, we decided to go with the Navitor, with a 27 Navitor. The thought concept with the use of Navitor was to allow kind of more stable hemodynamics given the left main and triple vessel disease and during the deployment, so the patient doesn't get unstable on us, but also provides better coronary access for later. So we used anesthesia, was GA, careful coordination for the inotrope support. No good bailout options if he got sick on us because of the peripheral disease, so the only option would be a balloon pump. And PCI, we were ready to do it at the same time, but obviously with the open carotid access, the plan was to do it staged if possible. This is the left carotid access, proximal distal control, kind of the crossing relatively straightforward. You can see the AI there. Actually, valve delivery was relatively straightforward, as you can see on the right, just came through pretty easily and positioned across the valve. And then one of the nice features of the Navitor system is that the positioning valve is pretty stable during your deployment, even without a lot of rail, not a lot of manipulation to keep it in the right position. Hemodynamics are pretty stable, even under pacing right here. Patient tolerated this pretty well, and kind of, you can see that it doesn't really move. Commissural alignment's maintained, so we do this in the cusp overlap, so you can see the two dots on the left of the screen and one on the right. Kind of verified our positioning here. So this was what Dr. Muhammad was talking about, is kind of hugging the lesser curvature, so not the greater curvature, but we figured when we released, it will pop up on the left side because it was a little deep on the left side there. And this is kind of showing the release, just nice and stable. And patient tolerated this pretty well. You can see the position stayed stable, no AI, good results. So hemodynamics did well, so we decided to wait, extubated him in the ICU afterwards. The valve gradients were good, and we brought him back to the cath lab 48 hours later for the PCI. So in terms of the coronary access was relatively straightforward. We had trouble, getting the guide fully in. So we used the guide liner kind of to support delivery. And then once we did that, we were able to get the guide in nicely. I don't know why these are skipping, sorry. This is after IVL of both sides, lesions pre-dilated, delivery of the stents. We did a DK crush technique, and now with a valve and no AS, the hemodynamics were well tolerated with this complex intervention, and kind of you can see final results of the left main was good. So in summary, I think transcarotid access is a good alternative for patients ineligible for transfemoral TAVR. The Navitor system delivers well via the transcarotid approach. I think the stable hemodynamics is a nice positive feature during valve deployment with the Navitor system, and it allows you to be less stressed as the operator in patients with high-risk coronary anatomy. And then the large cells are relatively easy for coronary access in patients who have a high likelihood for needing coronary intervention. Thank you.
A beautiful demonstration. So, Hatem, any comment?
So I think the ease of access to the coronary ostia hits down on the importance of considerations for lifetime management. This would be the perfect valve in patients who have unfavorable coronary ostial heights, where you have concerns about accessing the coronaries. It was beautifully demonstrated.
I think, again, one mechanism is that if you want to selectively engage the coronary, you should go to the short axis. You see, the longitudinal axis, you might go through one of the cells, but when you go to the short axis, you can't see exactly where is the orientation, and it becomes very easy to go in, because you mentioned that there was issue initially to go in. I think in these cases, I don't go to the longitudinal, I go to the short axis, and shows you exactly where is the entrance.
Yeah, I think
because the cell is very large, it's huge.
And I just showed the kind of couple still frames, but this was so getting the guide to sit well deep took the guideliner kind of to draw it in, but getting access was relatively straightforward. Getting the guide to sit nicely and deeply inside took a guideliner to help with that.
So again, wonderful case. One thing you demonstrated very well is that when you treat the valve, that's the best hemodynamic support that you can have, better than mechanical support or device, really, for left main PCI, and it allowed you to do atherectomy, like IVL, lithotripsy, and so on in the left main. But my question to you is, why did you opt to do the left main at a later date, and why not in the same setting?
Good question. Because of the carotid surgery, so keeping them on heparin after PCI, bleeding, the repair, so the surgeons were uncomfortable, and the patient was doing so well. So we were ready if we needed to. If the patient, I was shocked how well the patient tolerated the TAVR. They just had no hemodynamic issues. So if there was any suspicion, we were going to do it at the same time, so we were ready to. But given that he did so well, there was kind of no rush to do it. And the surgeons wanted, they're worried about bleeding at their transcarotid site, so we just let it at a separate time. So I don't know if anybody's doing it simultaneous. I've never had to do it at the same time with a transcarotid approach. So we've always done it kind of staged. Again, this case we were worried, so we were ready, but we didn't need to.
Oh, Ali?
So, I think managing those patients with severe AS, concomitant CAD, especially when they have LV dysfunction, is very challenging. And a lot of people feel more comfortable of fixing the valve first to give you that hemodynamic support before fixing the arteries. And, traditionally you worry about accessing the coronaries after using a tall frame valve. So I think this case very nicely highlights how easy you can access the coronaries after a Navitor TAVI. I do prefer doing those procedures as staged, so I fix the valve first and then do the coronaries after. There is some data that if you combine both PCI and TAVI on the same setting, you may have worse outcomes. You obviously use more contrast. And simplifying those very complex procedures may be key for success.
Yeah, I think so. I think so. That's just in general, our center's approach is, if it's patients are stable, tolerate, no issues, hemodynamics recover quickly, kind of stage it if needed.
We have a question from the audience. Right, yes, Mike, go ahead.
Mahmoud, was a nice case. My question regarding, in Navitor, we have a lower radial force in such cases, and so pre-dilatation balloon is mandatory. I appreciated that you didn't do a pre-dilatation balloon. Is it your way in doing these cases? You don't do pre-dilatation?
I don't believe it's necessarily mandatory, so I don't always know. So if it's not in every single case, so not as a routine. Much higher threshold to pre-dilate, definitely. So probably higher than, I'm probably like 5-10% with the Sapien, probably 20-30% with Evolute, and probably 50 plus with this, but not always.
So for Navitor, you are doing assessment for the leaflets itself for calcification, and you will decide which valve you are going to be dilated or not.
Exactly. If it's a very high gradient, very tight critical valve, high calcium burden, those are much more likely to do it. But this case wasn't the most a tight valve, but it wasn't the highest gradient or high calcium.
Leaflets are not so thick, so that you decided not to pre-dilate.
Yeah, the calcium score wasn't.
The calcium score wasn't
really
too
low.
high. Yes,
exactly.
was really low.
So I think it's my approach.
Yeah, I think based on IFU, generally we have to pre-dilate.
Yes.
I think this is important. It's the rare cases where you don't see much of calcium, more fibrosis, you don't predilate. But I think the message you want to leave is that by a few, you have to predilate. And the way to calculate the predilatation balloon is to go either to minor axis or perimeter-derived.
-1.
So I think we need a landing zone to be prepared, and the only way to do it is by predilatation. Now, when it comes to radial force, it's only on the initial release. When the valve is released, because it's nitinol, it has a radial force similar to the other self-expanding. It's the initial release, but it might flips down. But that's why the predilatation is very important. Mohammed Mkhini.
Just nice case, Dr. Mahmoud. The only concern is we are going for pre-dilatation or post-dilatation with rapid pacing with this tight coronary anatomy. That's the only concern. For this reason, in such cases, when you have a very tight left main, if you are going for maybe you go for self-expandable, but the balloon expandable won't be a good choice in such anatomy.
So you hear the question. He's worried about the pre-existing coronary disease with pacing.
Yeah, so I mean, that's another reason we didn't predilate on this one, and that's why we didn't use a balloon expandable valve in this case, is we were worried about him crashing and not a lot of support options afterwards. And that's why we kind of went with the more gentle deployment.
You know, I'm not trying to be different, but you see, it's mainly a fear rather than real. You see, if from coronary point of view, if the patient is stable, there is no angina, I didn't see that pacing brings an issue, you see, because you might need pacing in self-expandable valve. This is very important. So the idea going to the self-expandable because we don't need to pace, I think that might interfere with the deployment of the self-expanding valve. Why?
I think this is one of the greatest valve in case of poor ejection fraction. Usually patients, they tolerate the deployment perfectly without instability. We use it a lot in patients with low ejection fraction. My question to you, Mahmoud, why you didn't try to do, for example, lithotripsy for the iliac rather than go carotid?
That's a great question. My concern was mostly because of the gangrene, the distal bed. So this patient has gangrene and a lot of tibial, popliteal, distal disease, and so he was already having toes that needed amputated. And so it was I think that the vessels were treatable, but we would have further compromised his distal flow, and that's why. So the actual iliac disease wasn't untreatable, and I agree with that. But the feeling was that this would further compromise his already pre-existing PAD and distal PAD and his diabetic. So that's why we decided to go carotid.
Dr. Rayed?
For rapid pacing, it's an excellent case, but I think for rapid pacing, it is something really we need to be careful about, especially when you have very poor cardiac reserve, when you have very severe coronary artery disease, because we have seen patients died with rapid pacing after that did not go. So rapid pacing is very important, and I think what solutions we have, because the solutions what we do is mechanical supporting device to do both at the same time.
Okay, now because you mentioned this, rapid pacing is a range. You see, we are not talking about dropping the blood pressure when we do 180 or 200. If we need rapid pacing, this patient will be 120, 140, something like that. So that will not interfere. We fully address what you said, but I don't think it's a major issue when you need rapid pacing, particularly in self-expanding, because the concept that you will not pace in self-expanding might interfere with the perfection of location of the self-expanding valve.
But just to understand, for pacing, we need to go also with the blood pressure very down, very low, because if you do pacing without getting the blood pressure down, so what's the point of pacing?
Yeah,
getting the blood pressure down.
Are you talking about self-expanding or balloon expandable?
Maybe an advantage of Navitor that you don't need to pace. That's why, but sometimes we need to recapture, and sometimes the position is not right, so you need to do pacing.
Right, but now you don't need rapid pacing. You're just trying to decrease the cardiac output the cardiac.
Exactly, decreasing the cardiac output is decreasing the coronary flow.
Yeah, slight. I mean, but you don't have to go to zero.
Sorry to disagree. Now, when self-expanding, you need only 140 pacemaker. Doesn't drop the blood pressure. Doesn't touch it. We have seen it. We always release if we need under like 130, 140 pacing. The blood pressure doesn't come down. It stabilizes the cardiac motion, and you can deploy. But it's not like when 200 or it's not like pre-ballooning when you have to drop the blood pressure to 60 or 80. Mervat has a question.
So just very quickly, I think it is important that we emphasize that this patient has peripheral vascular disease and gangrene, but it's not infected, and so it is still safe to implant a transcatheter heart valve. Otherwise, it wouldn't have been done, and likely the safest is a valvuloplasty.
It was dry gangrene, and he needed amputations, and it was kind of borderline infected. So he had gotten a course of treatment, but he was not full osteo.
It's working.
For the basing, for the self-expandable, there is a trick, like from my practice. If the patient is heart rate 50, 60, if you go 100 even, it will work.
Yeah.
You don't need to go 100 for. So what is his baseline? Always look at the ECG. Yeah. 50, 60, 100 will do the job.
Agree.
So this patient we paced at 100, and actually what I do is when I do my testing run, I test at 100. If the pulse pressure is a nice and like 30, 40, that's what I'll pace at. So I don't need to go much. Yeah. So based on when I do my pacer testing is kind of how I decide.
I'm the
one, 100 or 120, something like that.
I'm the one who put the pacemaker for you. So that's why
Mahmoud, please go to the next case. We choose another challenging peripheral axis.
All right, this one is a little bit less controversial, hopefully. So another end-stage renal disease patient, I don't know this, Navitor, I seem to use it a lot in these end-stage renal patients, but this is a guy, end-stage renal hemodialysis, history of prior PCI a year ago, stroke 6 months ago, left-sided weakness, the trio of diabetes, hypertension, hyperlipidemia, and basically primary symptom is hypotension during hemodialysis at this point, and actually has some exertional dyspnea, though he's limited by his stroke. Echo shows an EF 60%, valve area of 0.8, mean gradient of 31, DVI 0.23. I won't show the coronaries, but he had a patent prior RCA stent, small circ with a 70% osteostenosis, otherwise mild diffuse disease. So in terms of the annulus and aorta measurements, the challenge, just an interesting part on the annulus, 66 is the perimeter. Small for the annulus if we were to go balloon expandable, but a very oval annulus. So measured 14 by 24. LVOT was stable, but very good sinus sizes. SCJ height was good. SCJ was a good size. Coronary heights were good. Calcium score of about 2,000. Angle was also okay for approach. So in terms of the peripheral anatomy, again, not the most difficult anatomy, but I think those most of us will see when we have this double kissing circumferential calcium at the aortoiliac junction. Those are probably some of the hardest to cross. And so measured 4.5 by 6 on the right, 3.5 by 5 on the left. This is kind of how we prepare our slides, kind of when we for our cases we do. So in terms of the procedural plan, the access was facilitate transfemoral bilateral access. We usually use unilateral, single-sided access, but in this case, obviously, bilateral. So the initial plan was start with just a simple PTA balloon, 6 millimeters. If that gets a good result, we'll go ahead. If inadequate, we'll proceed with an IVL with a 7 millimeter balloon. For this, we chose a Navitor valve, and we made this choice for delivery across the peripheral disease and because of the oval annulus to allow for a self-expanding valve. And the wire was Confida. In terms of the pre and post dilation, again, we didn't plan for pre-dilation unless difficulty crossing, but we planned for likely post-dilation, given the oval annulus. So peripheral doesn't look too bad when you look at it here. Sorry, I couldn't save an image without DSA, so I couldn't see it, but you'll see it on the balloons here. I think you can see it here on the balloons. On the left here, We have the 6 millimeter balloon, still a big waste here, and actually tried to pass a 14 French, I tried to pass a 14 French sheath here, wouldn't pass, and so this is after 5 treatments of the IVL. You can see that the balloon well expanded there. And so this is just a 14 French Cook passing. You can see it gets hung up a little bit, so that always worries you, but it did pass, so how is the valve gonna cross? And this actually, I was pretty impressed. This is one of the first that I had this is a couple years ago with a challenging peripheral anatomy. You can see it carries the calcium, pull back a little bit, give it another run, and there it goes through. So those are always nervous moments when it's doing that, but it actually passed very nicely for the system. And again, so this is pre-vision. So this is one of the earlier Navitor cases, but you can see here that the location is very stable as you're deploying. Kind of start to pace here at 120. Hemodynamics are stable. Position doesn't really change much. And just take your time as you deploy the valve. Okay, nice height, about 3 to 5 as you'd like. Kind of take it in. Then here's the release, just a nice steady release. Picks up on the left side, stays stable on the non-coronary side. And pretty smooth. And then as expected with the oval annulus after the first deployment, this says mild to moderate, this is more like moderate. AI here, I'll let it play again. I don't know why it's doing this, but it's a pretty good amount of AI afterwards. So then we post-dilated with a 20 balloon. And then here is our final results. I think a trace to mild residual AI. Echo showed trace AI with a mean gradient of 3. So final echo at 3 months, mean gradient of 4, trace AI, EF 60%. So I think I just want to show this case because it highlights that can deliver well across challenging peripheral anatomy. It's very stable deployment and in a patient with a very oval annulus, so allows you to kind of manage it carefully and closely and then post-dilated with a good result. Thank you.
Thank you, Mahmoud. I think it's another beautiful case. It certainly shows us the peripheral access that this valve delivery is very easy. And I always think that it is related to 2 things. Number 1 is the integrated hydrophilic sheath, because I have seen you doing it in the lower aorta. You can rotate. When you rotate, the atraumatic nose cone takes the right direction. So I think that's a key element when it comes to the sheath. Now, what I like also about the case is that in the second case, you used Navitor, and the first one was Vision. So I think the first one was the last. You did it after this one, and Vision made it easy. It's on the screen there. That Vision, these new dots, the height is 1.5 millimeter, and below it is 3 millimeters. So if you really target, it will be 4.5. That's the recommended. So I think it makes it easy to test the cusp overlap first and the LEO view as you move. So 2 dots should be on your right side and 1 on the left. And when you go, probably will not change because of the stability. And the stability helps in driving it there, and again, it helps when you deploy. And then you use the marker. I think that's all our advantages. So we have seen the sheath, we have seen the deployment, and the other point, which is very impressive for me, is the always single digit. And in all my cases, always single digit gradient. And it stays for long, although it's intraannular. So I will ask Dr. Ali, why you think is this single digit with this platform?
Yeah, Dr. Mohammed, I have to agree with you. I'm very impressed with the hemodynamics of the Navitor valve. You rarely see double-digit hemodynamics. And it has to do with the leaflets, the way the leaflets are sutured. It gives you a very large effective orifice area, and we'll show this with the Vantage trial I'm going to present very soon. But I do agree with you, the hemodynamics of the Navitor valve, despite this being an intra-annular leaflet design, it gives you a supra-annular hemodynamics, which I find is very, very interesting.
Perfect. Hatem. I think it comes to the design of the stent. It's a straight, while other self-expandable tend to be like you have inflow and then you have a waist, and in the waist you put the leaflet, so you have a smaller space. Intra-annular, this device is a straight segment, so you go all the way. That's why it's better even than balloon expandable in the annular. And we know from the study about Edwards, for example, is the average is, if we talk about effective orifice area, indexed is 0.4, 0.45 for Edwards, while it is 0.6 to 0.65 for this platform, while it is interannular. So I think it has to go with the area available for the leaflets. Mahmoud, do you have to comment?
Actually, since we have some time, I was going to ask Hatem a question on his case, because I'm curious what you did. You had great commissural alignment on your case. For Navitor, we usually can adjust the commissural alignment in the descending. How are you doing it how did you do it? Did it just go right to that right location, or how did you adjust for when you were delivering? Did you go at standard where you keep it at 12 o'clock, or did you have to do anything? Because it looked ideal, but did you do anything to adjust it?
We didn't do anything differently. Once you're in the annulus, then it's a standard steps.
So literally, just from above, it's always trickier because you don't know how it's going to rotate coming through the vessels.
And really, what's unique also about this valve is the paravalvular leak. Most of our cases no paravalvular leak, and I'm sure your last case, with time, it became trace, so it's continue the scare, to interact with the blood, and it relax and it take the shape of the annulus. Really great valve.
So I agree. It's not interact. You see, when the systole, it contracts the seal. With diastole, it dilates. It's dynamic. Even if there is an attempt to have a leak, it fills this wrap and makes it obstruct the paravalvular leak. So the design in this aspect is also exceptional. I think we will move to you, Ali, and then we'll have another discussion. Thank you, Mahmoud.
Okay, well, thanks for the kind invitation. It's really hard to keep up with those very nice cases and great presentations. But what I'll do today is to spend the next 10 minutes talking about the Vantage trial, the 30-day and 1-year outcomes. So those are my disclosures. So the Navitor TAVI system was first approved for the treatment of patients with severe symptomatic aortic stenosis who are at high or extreme surgical risk. And this is really based on the Navitor IDE study. But since then, the indication for TAVI has evolved, expanded. Now we have evidence to treat asymptomatic severe aortic stenosis with TAVI based on the early TAVR trial. Also, the age cutoff for doing TAVI has been reduced recently based on the new guidelines. So it's really important for the Navitor valve to be tested across all surgical risk profiles. And this was the question of the Vantage trial. So it was aimed to evaluate the safety as well as the performance of the Navitor system in patients with severe symptomatic aortic stenosis who are really at low or intermediate surgical risk. So this is the design of the Navitor valve. It's a very unique design, self-expandable valve, but intra-annular leaflets. You can see that it has large cell design to minimize coronary obstruction and allow coronary access post-TAVI. It has curved aortic cell, and this is aimed to reduce the risk of injury to the native structures very large sealing zone. There is an inner as well as an outer skirt to reduce the risk of paravalvular leak. And the valve comes in 5 different sizes, the 23, 25, 27, 29, and 35 sizes that actually covers a wide range of annular diameter, anywhere between 19 millimeter to 30 millimeter for our patients. So the Vantage trial is a prospective single-arm multi-center study looking at patients with severe symptomatic aortic stenosis who are at low or intermediate surgical risks. The trial enrolled 434 patients, around 203 in the low risk group, 231 in the intermediate group. There is also a valve-in-valve cohort that will be presented. So the results of those valve-in-valve cohort currently is not available. The inclusion criteria, those patients had to have a low or intermediate surgical risk based on the STS risk score. So you can see it was calculated at below 7% 30 days. They had to have severe true aortic stenosis, so the valve area should be less than 1. The mean gradient was more than 40, or they had a Vmax of more than 4 meters per second. So this is a population of true severe aortic stenosis, not low-grade, low-flow, or paradoxical low-flow, low-gradient patients. Patients with bicuspid morphology, patients with prior prosthetic heart valve, mixed aortic valve disease where the regurgitation is the predominant pathology, or patients with severe MR, severe TR, those patients were excluded from the Vantage trial. They followed up patients at different time intervals at 30 days and 1 year, and this is what we're going to present today. But the plan is to keep following up on those patients up to 10 years. So the goal is to have long-term follow-up for those patients as well. With regards to the endpoints, there is a primary safety endpoint, but there is also a primary effectiveness endpoint. So the safety endpoint is all-cause mortality, fatal stroke, or stroke with disability at 1 year. The effectiveness endpoint is looking at moderate or greater paravalvular leak at 30 days. So this is the study leadership, and you can see the study PI is Dr. Van Meegen from the Netherlands, Dr. Stephen Worthy from Australia, big steering committee and core labs from Washington, DC, and Vancouver, BC in Canada. So 36 sites from 11 countries participated in this study. And this is the baseline characteristics of the patients. You can see that the mean age was 75 years for the low-risk group and 79 years for the intermediate risk group. I think one of the great things about this study is the representation of females. Almost half of the study population were actually females, which I think is a great point. Those patients had a low STS risk score, as you can see, 1.5 or 2.6. And they're really a low frailty score too. So the frailty score was very low. So those are very low risk, not really comorbid patients. Less than 10% of those patients had right bundle branch block at baseline. And you can see this is a population of normal LV ejection fraction. The mean gradient was 48 prior to TAVI, and the valve area was 0.7. So with regards to the most common valves used in this study, it was mostly the 29, 27, 25 valves, less of the 23, less of the 35 valve. You can see that 90% of those patients actually had pre-dilatation done, and only a third of those patients required post-dilatation. Technical success was achieved in 97% of cases, which is a high percentage. With regards to the primary safety endpoint, all-cause mortality, fatal stroke, or stroke with disability, the observed rate was only 2.3%, so the primary safety endpoint was successfully met. Whenever we talk about composite outcomes, it's really important to look at the individual components of the primary outcome. So you can see the all-cause mortality at 1 year is actually below 1%. There was no fatal stroke. Stroke with disability was 1.5%, which is kind of in keeping with the standard practice for TAVI and other valves. Now, with regards to the primary effectiveness endpoint, that was successfully met as well. So there was no moderate or greater paravalvular leak at 30 days. And as Dr. Mohammed Al-Ataibi was saying, the NaviSeal technology is really made to reduce the risk of paravalvular leak. It's an active seal that is synchronized to the cardiac cycle, so it actually adapts to systolic and diastolic motions. And this is designed to reduce leak in patients with challenging anatomies. So patients with concentric calcification, calcific nodules, the NaviSeal actually works really well. With regards to safety outcomes at 30-day, there is really low risk for cardiovascular, non-cardiovascular mortality. Stroke was below 1%. The rate for pacemaker implantation at this study was 18%. And I think this is early experience. As we learn more about this valve, I do believe the risk of pacemaker implantation will potentially decrease. I see Dr. Fadi is not happy with this comment. But the other thing to comment here is this is the old version of the Navitor valve. So this is not the Navitor Vision. The new Navitor Vision has 3 radio-opaque markers at 3 millimeter from the annulus. And we do think that this may actually reduce deep implantation and hopefully reduce the risk of needing a pacemaker for those patients. As we discussed earlier, hemodynamic performance is really good with this valve. Post-TAVI, you see a single-digit number, but what's really impressive, that single-digit number actually stayed single-digit at 12 months, and this is very nicely shown in this slide. There was really no moderate or worse paravalvular leak in the Vantage trial at 30 days. At 1 year, there was only 16% of patients with mild leak. There is no moderate, no severe leak for those patients. Patients reported significant improvement in their symptoms based on the NYH class as well as the KCCQ score systems. At 12 months, you can see there's really no patients with class 4 symptoms. There was below 4% of patients at 1 year who had class 3. Most of patients had class 1 symptoms, so 70% of patients had only NYH class 1 at 12 months. So as with any other trials, there's always limitations to any study, and this is a single-arm trial that really doesn't allow comparison with other platforms. There is a 30% screen fail, so that may have introduced some selection bias, and the 12-month outcomes I just presented were only available for the first 262 patients. So to summarize, the Navitor valve has demonstrated favorable safety and performance at 30 days and 12 months for patients with severe symptomatic aortic stenosis at low or intermediate surgical risk. Both the primary safety and effectiveness endpoints were both met. This valve provided favorable hemodynamics and a single-digit gradient at 12 months with no moderate or severe paravalvular leak. So those results support the expanded indication of the Navitor valve for low to intermediate risk patient. This is now CE marked approved for those patients at low surgical risk. And the full paper was recently published simultaneously in JACC Interventions. Thanks for listening.
Thank you, Ali. Great presentation. I think it kind of highlights some of the data, but maybe a few points. I think we've discussed a lot of the points already. But maybe pacemaker rate. So you mentioned it's similar. These numbers to me look similar to what we see with other self-expanding valves. I don't know, is anybody's experience, does it seem to be higher, lower, the same? And the clinical practice? Mirvet or Hatem maybe?
So it's interesting because the initial self-expanding data had a much higher rate of pacemakers. And I think with time, with different iterations of the valves and the operator experience, implant depth, et cetera, I think we're starting to see much lower both PVL and pacemaker rates, which is very reassuring. And I think as we go down in the risk profile of our patients that we're offering TAVR, low and intermediate risk, our threshold for these has to go up. We should not accept it as often. I think these are preliminary data that is reassuring, 200 patients. I think we are going to need to see intermediate and long-term outcomes, but the one-year results are certainly reassuring.
I think Ali mentioned it. This Vantage is Portico. It's not Vision trial, the Vision platform. The Vision has these dots. So you can help in having shallower implantation. I think when you use the vision, I think you will have lower. Go ahead, Ahmed.
2 points. Do you think that the pacemaker rate is because of the pre-dilatation and the required pre-dilatation rather than the valve itself? Because the opening force is somehow weak, radial force is good. So doesn't it make sense that it's the valve itself, it's maybe the balloon interaction to the membrane septum? Second thing, I'm very interested to know what will happen to this Navi seal after, let's say, two years. This dynamic movement of the diastole, when it has epithelialization, and then how it will act. Is it going to take the shape of the vessel? Maybe this is something to see in CT scan post.
I will answer your second question. From the available data for explant, from that they needed to go for surgery, they saw it that it's endothelialized. So it acts till it is endothelialized, and then so it takes the system to prevent paravalvular leak till the complete endothelialization. So we know it from the explant. It's limited number, but I heard the surgeon comment on that.
Yeah, I think from my side, I haven't seen pacemaker being higher. I've done probably around 40 cases, 45 of Navitor. We have 3 pacemakers, and all 3 were kind of high risk cases, bundle branch block, pre-existing. So I don't, at least in my equation of how I select which valve, I do have a selection between balloon expandable and self-expanding in terms of pacemaker rate, and so that does enter the criteria, but pick one valve or another doesn't seem to have a higher rate, at least in my thought when I think through it. And the seal looks great. I mean, paravalvular leak, I haven't seen any with these valves. I think I think across all platforms we've gone away from PVL being a major issue across the board.
I think Ali mentioned it. 0 in Vantage, 0 moderate paravalvular leak, 0. There's nobody with moderate paravalvular leak. The majority no leak, and then with paravalvular leak, and then mild paravalvular leak.
I think for the study, for the intermediate and low risk patients, we are comparing them for the surgical, isn't it? To take these patients from the surgical option instead of that to do it. So it's very early actually to conclude whatever we have results, because even for the complications, it is expected to be less than in severe risk patients. So those patients, they will have lower complication, even in the long term or the short term, but we will compare them with the surgical. So I think it is too early actually to conclude, because the main problem is the long term, isn't it?
Yeah, and what surgical data? The surgical data, a long-term endpoint is need for reoperation. So you can, unless the surgeons, Murphat is, I think I need her comment, unless the surgeons move to the same clinical endpoints we have, that you go to the gradient, they don't care about the gradient, they create reoperation. Go to the surgical literature and see what is their definition, is mortality or the need for reoperation, that's all. So I think if we were to compare it, we have to have a long-term need for TAV and TAV, for example, as a primary endpoint. But when it comes to these paravalvular leak pacemakers long-term, I don't think we have enough data from the surgical literature. Because we were not competing with them. Now maybe they are trying to rethink what is their long-term parameters.
I think I kind of agree. We moved away from surgical risk. If you look at the guidelines, like the American guidelines, 65 years and above is a class 1 indication for both surgery and TAVI. And TAVI has now become the preferred treatment strategy across all surgical risk groups. I think the major question now is durability, lifetime management, feasibility of a repeatable procedure. But I agree, it's become standard of therapy for low-risk patients to undergo TAVI.
So if I may just make a small comment, I agree with you, by the way. I do not think the surgical data is our benchmark here at all. Just a small comment about age. The European guidelines actually use 70. The American guidelines are in the process of being revised. I'm sure the 65 is going to change. And I'm sure we're going to start talking about lifetime expectancy and factoring that in rather than an absolute number for age. Nevertheless, you presented data from low and intermediate risk, and the patients that were enrolled were 75 and 79. So I think we have to be very careful about equating age with risk profile. So somebody who's young is not necessarily low risk and is not necessarily intermediate risk, and we need to be very careful when we interpret and plan lifetime management.
Excellent points.
So I think we're behind time. So I think thank you everyone for a fantastic discussion. I think we learned a lot on this from these cases and the presentations, and I think off to lunch.